It's lovely to see all of you here and see your names coming up on the screen. So thank you for supporting this event. I've just got some basic Zoom kind of housekeeping. Please keep yourself on mute throughout this this presentation webinar. Can we? We're suggesting that people put their questions in the chat box on Zoom, or if you're on the Facebook Live event, you can write your questions in there and they will be channeled through to us. This event is being recorded and it will be on our YouTube channel, so you can pass over to colleagues. So you'll be able to pass over to colleagues that they can watch that. Although the slides are not cannot be available, we can share some of the links, so that will be possible to put those in a place that can be shared. So I'm just going to introduce and welcome Rabiya today. We're really fortunate to have Rabiya. Dr. Rabiya Majeed-Ariss gained a PhD from the University of Leeds in 2011. She's been doing research at St Mary's Sexual Assault Referral Centre for the last 5 years. Through this work, she's developed expertise in the areas of sexual assault research. She's developed expertise in the areas of sexual assault research through work in various projects in the domain of mental health, learning disabilities, SARC, service user experience, SARC staff experience, child sexual abuse and child sexual exploitation. Rabiya is also on the SARSAS Learning Disabilities and Autism Professional Advisory Group and is speaking with us today about intersectionality in relation to learning disability. So I will hand you over now, and if you would like me, shall I start sharing the presentation?
Yes, please, George. Yes, please. So thanks, Georgie, for that introduction. And I just want to start by saying thank you to SARSAS for inviting me to present this work as part of their digital campaign on sexual violence and people with learning disability. It's really quite an honour to be involved in this 16 days of activism movement. And I think, like many of us that work in this sector, I don't always make time to reflect on my job and think about it within this wider movement that I'm a small part of. So as part of the preparation that I was doing for today's presentation, I did take this opportunity to really reflect on the role and the work I do and reframe it as an act of activism. And I found that reflection really empowering itself, and I'd highly recommend that everybody that's here, that's made time to come to this presentation, just take a little bit of a moment and think about just our being here and our being part of this conversation. That in itself is an act of resistance. So thank you everybody for attending today. I'm really pleased to have this opportunity to share some of the research I've been working on. And I hope that we can have a really fruitful discussion towards the end of the presentation today. So I've been following this, the 16 days hashtag online, and I think the theme that's been used this year, it's really fitting around the shadow pandemic. And at the outset of Corona, at the outset of this virus, we heard a lot about how this is a virus that doesn't discriminate and how it can affect anybody in society. But as time's gone on and the months have gone on, we've learned, haven't we, that some groups are suffering more than others. We know that some groups are more likely to get the condition and have worse health outcomes. So that, we know that elderly, people from Black and minority ethnic groups and people from lower socioeconomic groups have worse health outcomes. So in the way that in principle, the pandemic can affect anybody, that's true for the shadow pandemic. We know that gender-based violence can affect anybody, but it does affect some groups more than others. And there are these health and social inequalities that exist. And I think some of these are the constructs that I'm going to try and unpick in the presentation today. So as Georgie mentioned in the introduction, I work at St Mary's Sexual Assault Referral Centre. And before I kind of get into the presentation, I think it's really worth just giving you a quick overview of that service, because that's the service where the research, a lot of the research is based in that setting. And not everybody will be familiar with that SARC. So St Mary's Sexual Assault Referral Centre is based in Manchester. It was the first sexual assault referral centre in the country, so we're really proud of our pioneering traditions there. I think it was established in, I don't want to say exactly when, but it's in the early 80s, and now there's over 40 such SARCs based on a similar model around the country. And at that time, St Mary's was developed to have a better setting to deal with the forensic medical response to rape and sexual assault. Before SARCs existed, often the forensic examinations were happening in police cells, and obviously that's not best practice anymore. So we've come a long way, but really this is a fairly new area of medicine still. So we're still learning and the evidence base is growing. So while there's over 40 such SARCs in the country now, St Mary's remains to be the busiest single site. So in 2019, we saw over 1,200 clients that attended the service, and that's just for a forensic medical examination. So seeing this large patient base is what allows us to do the research that we do and to be able to carry on building the evidence base in the area. So St Mary's, as well as providing the forensic examination, they've got a follow-up, ISFA service and a counselling service, all provided in this integrated model of care. So as Georgie mentioned, I've worked at St Mary's for about 5 years, just over 5 years now. And in that time, I've developed various themes of work. But today I'm going to take this opportunity to talk about intersectionality in relationship to learning disabilities. So I'm going to just give you a quick overview of what I'll be talking about for the next 50 minutes, an hour or so. So I'll start with giving a little bit of background on the literature around learning disabilities and sexual violence. I'm not going to go into a lot of detail here because I know that the audience is going to be clearly quite familiar with this area. I'll talk very briefly about what definition I'm using for learning disabilities. And then the majority of the presentation is going to focus on this research journey that I've been a part of. So it starts in 2014 at St Mary's when there was an audit done and a service evaluation focusing on people with learning disabilities that were reporting sexual violence. Then I'll talk about how on the back of those findings we were able to apply for some funding and talk about what we use that funding for, because spoiler, we were successful with that funding, so that allowed us to get onto the next stage. So I'll talk a little bit about our Easy Read leaflets and our Prevalence research study, and then I'll talk a little bit about the study that we're doing that followed the Prevalence work. That work is currently in preparation, that paper's in preparation, but we've done some preliminary analyses, so I'll present some of those, and then we'll talk a little bit about where I think the next steps seem to be for us in this piece of work, in this research. But I think hopefully we can have some discussion around that at the end as well, about what other people think are kind of important next steps, and what it'd be really good to get people's feedback as well about what we're thinking about doing for the future, and what we think of as the priorities. So if we go on to the next slide, please. Thank you. Okay, so I'll start with talking a little bit, as I said, about the background of the literature in learning disabilities and sexual violence. So something that surprised me when I first started looking at this area was that this notion of sexual abuse amongst people with learning disabilities is still fairly new. It was only brought to public attention about 30 years ago. And at that time, this fact was treated with a lot of denial and a lot of resistance in society. But over time, studies continue to say the same thing, that actually people with learning disabilities were more likely to experience sexual assault. And quite disturbingly, the other side of that coin was that not only were people with learning disabilities more likely to experience sexual assault, the support that they received post-assault was less available, it was less meaningful for this group. So that's kind of quite a worrying start anyway. Then when you look at the literature a bit more, one of the things that, while it was increasingly accepted that rates of sexual violence are higher in people with learning disabilities, when you actually look at the literature to look at what is the reported rate of prevalence, there's a huge disparity in what the reported rates are. And the reasons for this disparity are threefold. There's three main things that I could see when I was looking at the literature. So one of the big issues was this prevalence rate varied based on how the study population was sampled. And unfortunately, a lot of the work, it wasn't very clear what the sample was. It wasn't a very rigorous, replicable sample. There was also inconsistencies in how sexual assault itself was defined. So some authors, some research, we were only considering contact sexual assault. Other researchers were only considering penetrative sexual assault. So that led to inconsistencies in the rates of prevalence that were being reported. And then finally, another big issue in this area was a lot of authors were conflating learning disability with learning difficulty, and the definitions that were being used weren't always very clear. So while it was agreed that the rates of prevalence are higher in people with learning disabilities, the actual rate of prevalence itself wasn't very clear, isn't very clear still in different contexts. And what that means is it makes it very difficult for, when we think about direct action, we think about activism, we think about raising awareness, pushing a cause. It makes it really difficult for us to kind of inspire change with policymakers or, allow for change in practice when we don't have that clear figure of prevalence, because having that evidence is what allows us to say a service needs to be commissioned perhaps differently for a subset of the population to how it might be commissioned at the moment. So it's really important that we think about that, and I'll come back to this issue of prevalence. So kind of coming to the modern day now, so as I said, while it's agreed that there are higher rates of prevalence, but the actual rate of prevalence is disputed, there still persist misheld beliefs about sexual assault and people with learning disabilities. So I've just got a few that I'd like to mention very quickly. As I said, I'm not going to go into a lot of detail in the background here. So one such misheld belief is that people with learning disabilities aren't necessarily sexually mature, or they're not necessarily sexually active. And sometimes because of that, there's sex education can be withheld from people with learning disabilities, which in fact actually can make people more vulnerable to sexual abuse. By not having sex education, there can be a lack of understanding of social conventions, as well as perhaps having fewer personal relationships, and that as well can predispose people with learning disabilities to sexual abuse. And moreover, the learning disability itself might impair an individual's ability to evaluate risk, and that can make, that can be weaponized by a perpetrator who's wanting to exploit somebody because of their learning disabilities. So last week's presentation by Claire Bates from Supported Loving talked about this notion of people with learning disabilities as being individuals who've got sexual rights and are sexually active beings. So I think, that clearly demonstrates that these misheld beliefs themselves are things that we can that are important to do work on and raise understanding about. So another misheld belief is that people with learning disabilities, because they are better safeguarded, they're less vulnerable to sexual assault. And this again is misheld belief, because we know that the imbalance of power that can exist for people with learning disabilities with carers in itself can make people more vulnerable, to abuse. It doesn't necessarily in all cases, of course, but this is something that might make somebody more vulnerable, not less vulnerable to assault. Difficulties with communication and an increased dependence on others. All of these are elements that that the safeguarding, while in some cases it can be a protective factor, we can't just discount that in other cases in itself, it can be something that does lead to sexual assault. So these are some of the misheld beliefs. And then the final one that I've kind of noted on this slide is that people with learning disabilities are less likely to be psychologically impacted by the trauma of abuse, as they lack cognitive capacity to process it. This is a really problematic belief because it's kind of conceding that, okay, people with learning disabilities, they might be more likely to experience sexual assault, but if they do experience it, they're less likely to be distressed by it, or they're less likely to have a long-term impact from it. And this is very problematic. And this is what some of our research focuses on. So I'm not going to go into a lot of detail here, but I will be referring back to this point later on in the presentation. So this is the definition that we've used for learning disability in our work. So it's a government paper on valuing people, and it's the definition's from 2001, but it's one that's commonly used in research. And it's, I think, because of what I mentioned as well in my own background slide, I think it's really clear and really important to be clear about what definition you are using. So for us, we use this definition, and this meant that learning disability includes where somebody's got a significantly reduced ability to understand complex information, to learn new skills and cope independently. And importantly, it's the learning disability is an impairment that starts before adulthood, and it has a long-lasting effect on their development. Okay. So at St Mary's, we started this theme of work on people with learning disabilities and sexual violence back in 2014, where we did an audit and a service evaluation at that time. And this is a paper that's been published in relation to that work. And this was published in 2017. So while these slides aren't going to be available, the individual slides, I've got the links to the paper. If anyone's interested in them, please contact SARSAS or contact me, and I'm really happy to share that. And if anyone has trouble accessing the journal articles, let us know and we can help with that too. So just before I kind of talk to you about the findings of this audit, I think it's important to say just very quickly what it was, why we kind of started looking at this area of work. So at the start, before 2014, it was just something that was seen in the service because we are a large service. So I suppose it allows us to kind of see trends and even anecdotal evidence, which is seen often as soft evidence. Sometimes that really is the start of research. That's the start of capturing hard evidence. So I think at the start, there's a few kind of cases where there was somebody with learning disabilities that was seen at the service, and it felt like we're seeing a disproportionate number of people with learning disabilities here. Maybe we should do an audit and look at whether that is truly the case. And it was that's what kind of influenced doing this work. Simone, who's a third author on this paper, she was a medical student who was involved in that audit at the time. So that's kind of where the work started. So if we go on to the next slide, please. So there's two main findings from this audit. Hi, Georgie, I think we've lost the slides. Thank you. So there's two main findings from the audit. The first finding was, one of the things we wanted to look at was prevalence. As I said, it felt anecdotally that we were seeing a lot of people with learning disabilities, but we didn't know what the evidence for that was when we looked at a wider set of our data. When we did the audit, we found that actually it was approximately 5% of people were reporting a learning disability, which was more than twice what's reported in the general population. this was important finding for us, but we had to kind of be mindful that we were seeing this in the context of the limitation that this is relying on self-report data. So we were asking people about whether they had a physical disability, any learning disability, or any mental health issues, and we were relying on them to self-report on that. So that was one of the findings. And then the other key finding was that people with learning disabilities, so when we compared that 5% to the 95% without that didn't self-report a learning disability, we found that the group that had learning disabilities were the ones also that were accessing less follow-up care. So as I mentioned, at St Mary's SARC, we have an integrated service. So we've got the forensic medical examination, but after that, you've got the follow-up care from the ISVAs and also for counselling. So for the ISVAs are, for anybody that doesn't know, they're the support workers that contact the person who's been sexually assaulted within 5 days of their forensic examination, and then they continue to support that person as long as is needed, and that's typically until, you know, and it can be for years if there's a court case, and it can really vary. And then the counselling service is also available at SARC, and this is an assessment for counselling is available to all of the patients that have attended St Mary's SARC following a sexual assault, if that's something that they wish for. So what we found was that for the ISVAs, people with learning disabilities on average were having 4 follow-up calls, and that was almost half what people without learning disabilities were accessing. And in terms of counselling, the difference was even more pronounced. So people with learning disabilities I think there was 3 people that accessed counselling in and outside SARC, compared to 13 people without learning disabilities that access counselling. So you can see a huge disparity there. So these findings, as is often the case, isn't it, with research, it answered a few questions, but actually it raised lots of new ones. So for me, some of the really important questions that came out of this audit was, how are the mental health needs of people with learning disabilities comparing to people without learning disabilities? Because there's clearly a difference in the follow-up care that's being accessed, and there's these misheld beliefs that exist around people with learning disabilities, impact of trauma from sexual violence. So what's the evidence? That was one of the key questions that came to us. And then the second question I was really interested was to look at how these follow-up services were operating, and were they operating in a way that was accessible to people with learning disabilities? Were they commissioned in a different way, or were they commissioned the same way? So these were the key questions that came up. We wanted to continue exploring them. So on the back of that audit, we went and sought some funding from NHS England. We wrote a bid, so we're just on the next slide, please. So the bid was looking to do work to improve the accessibility, appropriateness, and effectiveness of sexual assault services for people with learning disabilities. And we wanted to use this grant for 2 main things. So the first thing was to produce co-produce accessible leaflets for people with learning disabilities, and that we felt like would have a quick, a more immediate impact. And the second thing that we used some of the funding for was by introducing a validated screening tool for learning disabilities, and we wanted this to support future prevalence work that would supersede that limitation that we previously had, where we were asking people to self-report learning disability. So I'll talk first about this co-producing of the accessible leaflets. And on this slide, you can see that slogan on the top left, "Nothing about us without us." And this is a slogan that that was coined by the disability movement, disability oppression empowerment. This is a book, and it's a front. I think this has been used as a kind of title page in a book as well. So this slogan really communicates the idea that policy and practice shouldn't be decided by representatives without this direct participation of members of the group. And that's definitely something that we felt strongly about at St Mary's SARC as well. So if you go on to the next slide, please. So we went on and used the majority of that NHS England funding for the development of these leaflets. And that was done, I won't go through this in lots of detail, but I can kind of just give you a quick overview of what we did. So we ran workshops with Manchester People First, and that's an advocacy organisation for people with learning disabilities in Manchester. And through these series of workshops, Manchester People First helped us co-produce the leaflets. So right from kind of the start about whether or not we even needed leaflets, a leaflet's the best way to go for information sharing, right up to the end kind of product. We had input with that. And I think that's what kind of really made these leaflets a success, really. I think that co-production was such an important part of it. Originally, we had wanted to do these leaflets just for people with learning disabilities, to have like an easy read option. But then as time went on, it was like it became clear that other groups would really benefit from this leaflet also. So people with English as a second language, or people that have got limited literacy, or indeed people that are just coming to our service at 3-4 o'clock in the morning in a traumatized state with little sleep, who were given this information. Actually, why don't we just make easy read the status quo? And that's what we ended up doing. That, you know, that had positives, but kind of reflecting on it now, what it did mean was slowly more and more things did get put into this leaflet because this was the only leaflet we had. A way that we worked around that was by using this Zappa app. So it's really clever technology. So when you've got these QR codes that are embedded within the leaflet, this smart technology allows videos to pop up and play through somebody's smartphone or a smart tablet, whatever device. And what that meant was we had less information provided on the leaflets. But of course, that does rely on people having this smart technology and knowing how to use it. So that was, you know, while it was a benefit, we do know that did, you know, that not everybody has got the capacity to access that. So that's just something to bear in mind. So if we move on to the next slide, please. So on this next slide, we've got the actual links to these leaflets. And if you request it from SARSAS or myself, again, we can share these links with you. So in these slides, also there's a little picture which is of our leaflets that won some prizes. I can't remember exactly where it was, but we were really proud of it. And again, I think this is testament to the fact that that this is work that was co-produced. So these leaflets are available, they're freely available on our website. Part of the condition of NHS England giving us that funding was that we kept these resources so that they could be shared. So we'd be really happy for other sexual violence services to adapt these leaflets as they find appropriate. We would, of course, request that if you do adapt these leaflets, you do acknowledge St Mary's Sark in any of your adaptations, please. So that's where we use the majority of the funding in developing those leaflets. It's quite an expensive process, it turns out, but we had a small budget left that we'd written into the grant, where we used to purchase this validated learning disability screening tool. So that was LDSQ and the CAIDSQ. So if we go on to the next slide, please. So what we did was with this project, we wanted to answer by having this learning disability screening questionnaire as part of the service, we wanted to answer 2 main research questions. So the first one was, what is the prevalence of people with learning disabilities amongst the clients that were attending for a forensic medical examination? So as I already covered in the background slide, the wider literature, there isn't any general agreement about what the prevalence rates are in different settings and scenarios. And when we were looking at the literature, there wasn't any research that's previously given focus to this question about what is the prevalence in the context of a UK SARC, or in the context of any international SARC actually, what's the prevalence of a learning disability? And this felt like a really important gap in the knowledge that we were able to address by doing this research at St Mary's. So we bought enough of these questionnaires to last us 18 months at St Mary's SARC. So as I said, we had this child and adolescent intellectual disability screening questionnaire. So that's valid for children that are aged 8 and young people, so children and young people aged 8 to 17. And then that we bought the learning disability screening questionnaire, and that's valid for people aged 18 plus. So in the presentation here, in the paper, we reported the evidence for the learning disability screening questionnaire for adults only, but I know what we've been asked in the past, if there is anything available for children, for people who work in children's services alone, I imagine. So I just wanted to kind of mention that now. So the LDSQ, it's a commercially available and copyrighted and validated tool. It's designed in a way that it makes it quick to administer in a clinical setting, and it allows the person who's administering the tool to assess the likelihood of whether or not a person has a learning disability or not. So it's really important to remember that this is a screening tool. It is validated and it gives you a reliable and valid finding, but it isn't a diagnostic tool. And it's been developed so that it can be used in a variety of health settings, including healthcare, which we're using, but you can also use it in a social care setting and criminal justice setting. There's some really interesting work done by Glynis Murphy, who's from the Tizard Centre, who used the LDSQ in a prison setting. So yeah, it has been used with success in these different settings. And the main thing about the LDSQ, if we just go back to the previous slide, sorry, the main thing about the LDSQ is that it helps us overcome these limitations that I talked about earlier that exist with self-report data that we had in the patient notes audit. So we wouldn't now be relying on people to say whether or not they had a learning disability, but we would have be able to use this tool and based on that have an outcome of whether or not somebody's likely to have a learning disability. So if I talk a bit about the methods for this study, so just on the previous slide, the first thing we did was we got NHS ethics. And once we had that, we had the go-ahead to administer this LDSQ with every single client that was attending the service for a forensic medical examination. So we administered this with all of the clients that met the inclusion criteria, and they couldn't meet and none of the exclusion criteria. So, for example, if somebody had an interpreter with them, it might still be useful for a clinical context to kind of ask about certain questions about their literacy, for example, but the score that's generated from the tool, that itself isn't valid. So, but in most settings, it was an appropriate tool to use. So for all of 2017, we used this tool, and actually we introduced it a little bit earlier than that. So we gave it time for it to be kind of settled into the processes at St Mary's, so that it was being used consistently, and any of the challenges that kind of came up at the start, the teething problems, are all ironed out before we had this like 1 year's data. So by 2017, we had reliable data that we used. So we got the LDSQ score from the patient notes, and we also got data about demographics about the client, demographics about the alleged perpetrator, as well as characteristics around the assault. And then we were able to do some quantitative data analysis on all of that data set. So this work is now, I'll move on to the findings from that, but I just wanted to quickly point out that we've got this paper that's been published, and it's published earlier this year. And if anyone's interested after this presentation to know more about the study, then I would definitely signpost you to this paper, because it goes into a lot more detail than what I've got time to cover today. As I said before, if anyone struggles to access these papers, let me know and I can help with that. Okay, So onto the findings then. So in 2017, we had 56 adults that attended our service that scored as likely to have a learning disability on the Learning Disability Screening Questionnaire. So 56 adults translates to 8.2%. So that's 1 in 12 people that walk through our doors that has a learning disability. That's, you know, that to put that into kind of context, we know that MenCap reported in 2018 that 2% of people in the general population have got a learning disability. So that's 1 in 50. So what that tells us is that we're 4 times more likely to see somebody with a learning disability at a sexual assault referral centre than we are, you know, in the general population, like just walking around on the street. That's huge. So this is the first time that we've been able to identify that figure, because there hadn't been this prevalence research in a SARC context before now. So kind of it raises questions about why are people, clearly people with learning disabilities are overrepresented. Why are they more represented? Why are they more vulnerable to sexual violence? And there's probably lots of reasons for why this is. It could be that some offenders are targeting disabled people due to their perceived weakness or their perceived lack of credibility as a witness in the criminal justice process. And that's something that people that are health professionals and people like, that's something that needs to be considered when these services are being designed, in making sure that these services are accessible for this group that are more clearly, there's a higher likelihood of them experiencing sexual violence. I think before I move on to anything, I think it's really important for me to also acknowledge at this juncture that this prevalence figure that I'm giving you, this 1 in 12, this is only the people that are reporting sexual violence. This is only people with learning disabilities that are actually making it to a sexual assault referral centre and they're having a forensic medical examination. So it's widely accepted that there's a gulf, you know, in any type of, you know, in any population, there's a gulf in the actual number of assaults that are happening. So assaults that are happening behind closed doors every day, and how many of them are then reported to the police. And of that group, how many of them actually make it to SARC? We know that that gulf exists for people without learning disabilities. But when we think about people with learning disabilities in particular, I think it stands to reason that this gulf is going to be more pronounced, because we know that people with learning disabilities experience additional barriers in reporting sexual violence, perhaps in being believed when they report sexual violence, and for somebody else to potentially act for them. There's really good work that's been done in this area by colleagues that have looked at how people with learning disabilities can be the target of sexual exploitation rings, just of perpetrators that are repeat offenders, due to the vulnerabilities that people with learning disabilities have. So it isn't possible for me to comment, or for my research to comment on the true scale and nature of sexual violence amongst people with learning disabilities. All our work is able to talk about is this reported rates. But I think within that limitation, this is a really powerful figure, having this prevalence rate for the first time and knowing this is 4 times more overrepresented in the SARC, because we haven't had that data before now. So that is a really powerful figure, but it does have its limitations, in that it's only can talk about what's reported. So before I kind of talk about these results, the final thing I'd like to mention is that I've talked a lot in the kind of run up in the background about the disparity in previously reported prevalence figures and the problem I have with that, and the problem there is around that in general, not just that I have. But I think what is important is that we've overcome those limitations in our work. So this research is methodologically methodologically strong and reliable, because we're reporting on a specific population. So on the SARC population, we're defining learning disabilities consistently. We're using a screening tool to do it. The parameters of contact sexual assault are clearly defined, because these are people that are attending a sexual assault referral centre. A limitation of our work is that it's only focusing on one site. So this is just in Manchester. But we'd welcome, this work is strong, it's replicable. That's kind of what we wanted, and when we set it out to do it and when we developed the methodology. So this is ready for other researchers in other areas to replicate and see if this is a similar trend elsewhere. We know we've had interest from colleagues in Australia that are seeing the same phenomena there. They're seeing that people with learning disabilities are experiencing higher levels of sexual violence. So we shared work with them, and we're hoping to see what their findings are and how they compare with the UK context, with the Manchester context. So that's kind of the answer to the first question that we had, that we put at the start. So we know what the prevalence is now of people with learning disabilities reporting sexual violence. Now to go on and answer the second question. So the second question was, what are the demographics of clients with a learning disability when you compare them to clients without learning disability? So in this slide, what we're looking at is self-reported mental health. And what you can see here is the people that the rates of mental health are really high amongst SARC clients in general. So, but they are even higher amongst people with learning disabilities. So the prevalence of self-reported mental health is about 80% in people with learning disabilities, and that prevalence is about 60% for people without learning disabilities. When we did a statistical analysis on this data, we found that people with learning disabilities, clients with learning disabilities, are significantly more likely to report mental health issues than clients without learning disabilities. If we move on to the next slide, here we're looking at the self-reported rates of substance use. Oh no, sorry, I think I might have just missed a slide. Have we missed a slide there? Sorry. No, sorry. If we go on to the next one, please. Yeah, thank you. So we're on that slide, the one before, please. In this slide, we're looking at self-harm. So here we can see that clients with learning disabilities are more likely to report previous or current self-harm than clients without learning disabilities. So almost 50% of the clients with learning disabilities reported previous or current self-harm. And again, when we ran the analyses, we found that people with learning disabilities were significantly more likely to report self-harm than people without learning disabilities. So now on this slide, we're looking at substance use. Here we can see that clients with learning disabilities were twice as likely to report previous or current substance misuse than clients without learning disabilities. And again, this was a significant relationship. There's a significant correlation between the likelihood of having a learning disability and self-reporting substance misuse. Here we're looking at clients with learning disabilities and clients without, and how they report domestic violence. And again, we found a significant correlation, and this isn't a surprise, this is very consistent with the literature. Michelle McCarthy, again at the Tizard Centre, has done a huge amount of work around domestic violence and people with learning disabilities. So this finding was not surprising. We found again there's a significant correlation. So people with learning disabilities were significantly more likely to report current or historic domestic violence than people without learning disabilities. So in summary around those results, I think I'm okay for time. So in summary, when we compare that 8% of people with learning disabilities and we compare them to the 92% without, we found that clients that had a learning disability they were significantly more likely to self-report mental health issues. They were significantly more likely to report self-harm, substance use, and domestic violence history. So I think that this slide and these results demonstrate the intersecting vulnerabilities that exist in this group. And I think this is the best time to probably circle back to that belief that we discussed back when we were discussing the background, and there was that prejudice belief that people with learning disabilities are less likely to be psychologically impacted by the trauma, by the abuse trauma that they experience, and that they lack a cognitive capacity to process what's happening to them. Well, I think that this research evidence really blows that misheld belief out of the water, because what we're seeing here is clearly people with learning disabilities are reporting higher levels of mental health, higher levels of self-harm, substance use, history of domestic violence. So these people, this group isn't less vulnerable or having less psychological impact of the abuse. If anything, it's more. So on the back of that work was very much kind of like the broad brush work that we did in this area. And then we wanted to do kind of a deeper drill, because the notes at St. Mary's Sark are really detailed. So there's like more capacity to do like a deeper drill of those cases, of the 56 clients with learning disability, and compare them to a similar size control group, and look at in more details at additional aspects of like the client's mental health profile, about the context of the assault, and so on. So just to say that, as I mentioned, that these are very much like preliminary results I'm presenting here. This is the first time I'm presenting this data, and this is going to be different to the data that we present in the paper, because today I'm just presenting the descriptive stats. So I'm not able to talk about whether something's statistically significant or not. We haven't done those analyses yet, but even the descriptive data is really interesting to share, and I thought it'd be a perfect opportunity to share it here today. So if we kind of move on to the next slide, please. Okay, so as I said, this is just descriptive data, and you know, I'd be really, if anybody, if anything comes up in your guys' interpretation of these results, then feel free, please, to kind of bring them up in the discussion at the end. But these are just our initial interpretations. So if we look at the here, what we can see is that the location of the abuse for people with learning disabilities, this primarily, the abuse happens primarily in their own home. For the people without learning disabilities, the abuse happens primarily in the home of the client. So we are seeing quite an interesting difference there. And yeah, again, you know, if anybody's got any ideas in terms of interpretation why that is, then that would be great to hear. So if we can look at the next slide, please. Okay, so this is another interesting finding. If we look at the relationship of the client to the alleged perpetrator, we can see that for people with learning disabilities, or maybe we can start with, yeah, for people with learning disabilities, the most common perpetrator was an acquaintance that was known for more than 24 hours. So it wasn't somebody they classed as a friend, but somebody they knew to speak to nod at, and they'd known them for a while. When we look at the group without learning disabilities, the most common perpetrator is the acquaintance of less than 24 hours. And looking kind of just to give you a bit of context on that, that's probably quite commonly might be somebody that you might meet in a bar, in a pub, in a restaurant. So it's within, the assault happens within 24 hours. So we can see for our group with learning disabilities that bar is quite small. So that context is quite small. But when you kind of look at our group with learning disabilities in terms of if the perpetrator is a friend, family member, it's twice as common that the person that the perpetrator is somebody known to them. And also strangers. So again, for people with learning disabilities, it's twice as common that it's twice as likely that the person that's going to assault them is a stranger if you compare it to the group without a learning disability. So I think this relationship to the alleged perpetrator is an interesting one for us to unpick. And as I say, these are just preliminary findings. So I don't know how this is going to work statistically when we do further analyses, but just on that kind of face level, that's quite interesting. And if anyone's got any input about that, I'd love to hear it. So then if we now look at substance use, so this was interesting because as I just presented you with the data, so when we looked at historic substance use or self-reporting substance use, it was higher, significantly higher in people with learning disabilities. But in this further analyses, what we were interested in was what people were reporting as happening in relation to this incident of sexual violence that they then report to the SARC or to the police. So here, people without learning disabilities were reporting alcohol use related to the incident or drug use related to the incident. We found that people with learning disabilities weren't reporting as high levels of intoxication in the actual incident of sexual violence, but in general they were reporting high levels of drug use. So again, that might be something, it might be something contextual. It might be something to do with the nature, the context of the assault. So if you're meeting somebody maybe, in the evening, there might be some recreational drug and alcohol use related to that. That might explain this difference. But it's something interesting to know because it is quite different to the historic substance use that people with learning disabilities are reporting outside of the assault itself. So I think I've got about just 10 minutes or so. So I'll kind of move on now to the discussion. So I talked about this, the Learning Disability Screening Questionnaire that we introduced at St Mary's SARC. And so something to kind of mention is that we originally got that funding for 18 months to use that as part of our research project. But during that time, this was actually seen to be of great clinical value. And we've continued, and that cost has now been absorbed as a clinical cost, which is a great positive that I wasn't anticipating when we started the research. And I can't take credit for that. That's just a happy coincidence. But it shows, doesn't it, that it's not until we do things necessarily that we see the value of them. It's not until we try it. So I think hopefully, the fact that it's been of clinical value to us and it's something that we're routinely using, this is something that other sexual violence services can learn from and perhaps be able to adapt themselves and using their services. I know in the past that presentations like this has been something that people have been interested in, and also colleagues in the police force have kind of been interested in whether this could be something that they could use just as a quick tool that they can administer to try and identify additional needs. So I thought that was something that was kind of useful to share. And one of the reasons that we've continued using them, like why it's seen as of clinical benefit, is so what happens at St Mary's is every case is reviewed the following working day in a morning meeting, and just to check that everything has been done as it should be, and that meeting has a multidisciplinary team in attendance, and it's another opportunity to just do a safety net check of everything that needs to be done and have any further actions as necessary. And what we do is we review the case in an order. But what we were seeing was happening was sometimes there was a case that was being reviewed, and members of the multidisciplinary team, their spider senses would be like, there's something not right, there's something that doesn't seem right about this case, and they'd ask about, what was the LDSQ score, because they felt like there was a vulnerability in this client that that they needed to know about to contextualize the rest of the case that they were being told. And that was kind of what part of the reason that we felt clinically that this is a tool we should keep. As well as that, there was a really interesting case where we had an individual who attended multiple times within the 12-month period. I think 18 months when we actually had the full the LDSQ costed for research purposes. I think this person attended on 3 different occasions, and the perpetrator there was at least 2 perpetrators. There might have been 3 different perpetrators on the different occasions, so it might have been a repeat perpetrator. I'm not 100% on that. But when the doctor was writing her statement for court, she was asked to submit a police statement. One of the things that she came to speak to me about was the fact that this person had scored as likely to have a learning disability on their screening questionnaire, on their repeat attendances. Obviously their score was the same at each time, but this was something that she thought was really important for her to put in her statement and to talk about it within the context of their learning disability being weaponized by the alleged perpetrator. And following that, it was seen to be good practice for this to be, if somebody had scored as likelihood of having a learning disability, it was seen to be good practice to share this information routinely with the police. And the police tell us that it's to help them make decisions about whether or not somebody needs an intermediary when they're doing their, their best evidence interviews. So there's lots of, by us sharing this information, there's hopefully other benefits that it's having for that person. We're also sharing the information about their learning disability screening score with their GPs, with their consent. We know in the general literature about people with learning disabilities and health outcomes that people with learning disabilities have a higher rates of mortality from preventable or have a lower life expectancy. And some of it is for things simple as they haven't attended a screening, a cervical smear, for example, because they've received a written letter from their doctors. And if that person's got limited literacy and they haven't got a carer to help them with that, then that you can see why we have these worse health outcomes for people with learning disabilities. And at St Mary's Sark, we're in a really privileged position where when somebody attends for a forensic examination, that actual appointment is approximately 3 hours. So the examination doesn't last for anywhere near that long, but that whole relationship building, all of the medical history that's taken, all of that, we've got that time and we're able to get this information about their LDSQ score. So if somebody's scoring is likely to have a learning disability, we can share that information with their GP, and hopefully that can help them in other ways that we didn't anticipate at the outset, but it's been an additional advantage. In terms of undertaking the LDSQ, it's I'm painting a really happy picture, like we're continuing using this LDSQ, the costs have been absorbed clinically, it's being done routinely, we've overcome these teething problems. But that is true, but we did have these teething problems to start with, and I think there was a period of where we did really have to work hard as a team to kind of work out what is the best way to administer this tool, because people are attending for an acute examination after a sexual assault. There's these questions asking them about literacy. They might be asking them about how independent they are, whether they've had a job, and for us to get a reliable score, the tool had to be administered in a specific way. So that what we did was we had a training at the outset that I delivered, even though I've never used the LDSQ, but just from my reading and from my reading of the manual. And then we had a couple of meetings after that, where it's our crisis workers that are administering the tool with people that are attending the service. And at these kind of follow-up meetings that we had with the crisis workers, it was really interesting how it worked. But there was kind of troubleshooting within the team themselves, and people were sharing good practice or good tips, what worked for them. So over time, people were doing it really consistently, but they were sharing what kind of worked. So I think some of the things that I remember people saying was, it was helpful for the LDSQ to be kind of introduced quite early on, so people didn't feel like this was something that was judgment based, and also for them to be really clear that this is something that just to be clear and honest about what we were doing. So this was something that we were doing with every single person that was attending our service. And the reason we were doing this was so that we could provide a better service to everyone. And then, you know, so once we kind of ironed out those teething problems about what's the best time to introduce it and how should we introduce it and so on, over time, it's been really welcomed by staff. And now we're at a position that I think we'd, you know, we don't want to lose it. So it's been really nice to see that. But it does have a knock-on implication that, you know, there was that at the start, took that time from staff in terms of the training and kind of getting it bedded into the service. And it does take a little bit of time to actually do the tool itself. It's about 5 minutes, so it's not that long. But it is kind of just to be kind of transparent that it does have that. And also, you know, we had to deal with it really kind of sensitively, because we didn't want it to feel like we were being critical of individual members of staff performance. And it happened organically for us, really, because when we had those meetings, it was peers sharing tips. So it wasn't really somebody being critical, it was people seeing what was working. So it kind of happened really well. So I think they're like good practice that I can share if anybody is in the future interested in introducing the LDSQ in their service. So kind of just going to talk really quickly about the implications. So as I've already mentioned, what this has done for the first time is give us this definitive prevalence figure for people with learning disabilities that we didn't have before. And that means that we've been able to clearly demonstrate that people with learning disabilities are overrepresented in the sexually assaulted population. And it's kind of also demonstrated, as well as the people are more commonly assaulted, it's demonstrated the risk profile of people with learning disabilities. As I've already mentioned, the intersecting vulnerabilities, and I think that's been an unanticipated finding, but a really important finding, because we knew from the audit that the prevalence was higher, but we hadn't done a lot of that work about looking at these two different groups. So now we're in the position where we can, you know, say to policymakers, say to commissioners, that 1 in 12 people attending our service have got learning disability, and people with learning disability are more likely to present X, Y, Z, and that's why. And that's something we need to consider to make our service more accessible for this group. So just before I move on, so yeah, I think I've kind of already covered that. So it's just about the prevalence and the risk profile, kind of really emphasising the importance for this timely care. So kind of going on, I think we're on to our last slide. So that's, as I said in the overview at the start, I just wanted to finish with this slide and finish here, but it'd be great to get people's input on this. So that's been our journey to kind of getting to this point. And as I mentioned, you know, I've just done some preliminary analyses, but we're going to do some full statistical analyses and publish that second deeper drill paper. But we're thinking about after then, what are we going to do? What's the next step? So we've also done this other study where we looked at repeat attenders. And in there, we saw that people with learning disabilities are more likely to be repeat attenders also. So it's kind of thinking about, is there a safeguarding issue there? Like, how are we seeking to identify people with multiple vulnerabilities? Is there an issue around masking? You know, are we focusing on one variable like learning disability and ignoring or not exploring others like mental health? How are services set up at the moment? You know, are they set up looking to focus on needs of different groups? So if 1 in 12 people have got a learning disability, are we is it a one size fits all, or are we doing anything differently? And I know at St Mary's, you know, this has been a long fight for us. We've been trying to like right from when we did that audit in 2014, it was the start of us trying to get the evidence to support what we kind of knew, what was known clinically, that this was a vulnerable group. We did see more. We didn't know that in the detail that we know now, but that's kind of what all the hunch was. I'm really pleased to say that this is the first time I've actually been able to say it in a presentation, because it's, yeah, we're finally at that point that we now got a learning disability ISPA for the first time at our service, who's going to be working with children and adults. She's just joined our service. We did an induction last month. So once she's settled in, I think we're going to be looking into how we can evaluate that role. I know there's been other LD ISPAs around the country, not many. I know there's one in Bristol who I've met, and I only learnt about through my work with SARSAS. So it would be really good if one day, you know, this role was the status quo in every SARC in the country, but that's something that we're, you know, hoping to evaluate at St Mary's, and hopefully that can make a case for other places. And the other thing that I just kind of wanted to talk about finally was this finding around people with learning disabilities having worse self-reported mental health, and what should future work in this area look like. You know, we've talked about how thinking around the access of follow-up services is important. So maybe work around the uptake, the satisfaction for people with learning disabilities. This is potentially something that I want to do a fellowship in the future, and I really want to make sure that, you know, whatever my fellowship is, it's what's the thing that's most needed. So so again, it'd be really helpful to hear people's thoughts around the importance of this, and any steer that they'd like to give about future research looking at people with learning disabilities, sexual violence and mental health. So I think I'll leave it at that. I've got a bit of time still for discussion.
Great. Start. Okay, thank you. I actually can't see myself, which isn't the worst thing in the world, but can you see me, Rabiya?
I can see, yeah.
Great. Well, thank you so much. I just felt that was so relevant and, you know, I mean, tragic statistics, but really backing up like what we're seeing at SARSAS, and how wonderful that this work has been done. So we've got some comments. Great, Rabiya, this has been brilliant. Thank you for sharing your work. So I'm going to start looking at the chat box. We did have something that I can ask now before I have a look at the questions around autism and your sort of thoughts. You talked about the LDSQ and the screening, and I didn't know if you had any research about autism or any thoughts about autism that you'd like to share.
Yeah, no, definitely. Well, I think it's notable by its absence, isn't it, that in this presentation I don't talk about autism at all. At the outset, the reason we didn't do that was because there isn't, well, we were focusing on learning disabilities, and part of the reason for that was because there are screening tools that are available for learning disability that you can administer in a clinical setting. I'm not sure that that's something similar exists for autism. I think it's a really important area to consider. I had a discussion with a colleague a while ago now, but she talked as well about autism in females and how it presents, and how over time that's changed. Like the understanding of autism in females has changed, and how there's a history of that being misdiagnosed. I think this is a really important area for research, but I have to admit that my research is focused on people with learning disabilities, and that is definitely a limitation. We haven't considered autism. I'd be open to conversations and discussions with researchers that do research, have researched with people with autism previously, and to see how, you know, whether we see similar parallels in this group that we are seeing with people with learning disabilities. But yeah, at present, that isn't something that I personally have looked at.
Thank you.
But I'm sure it's of value. So yeah, if anyone else has or can, great.
Yeah, I would say, you know, if there's any good research, it would be really important for us to share for this campaign. Okay, I'm just going to read these. The stats of for 2019, are those solely victims from the Northwest, or is this from a wider area? So I think that's talking in relation to the Manchester SARC. So was that, what so area does that cover?
I think they're referring to the background slide when I said there's 1,200 people that attended for a forensic medical examination. Yeah, so that is just that's just people that attended St Mary's SARC. So at St Mary's, we provide forensic examinations for Manchester, Greater Manchester and Cheshire. But the follow-up services for Cheshire are provided locally, but the follow-up services for Manchester are provided at St Mary's SARC. But the forensic is for Manchester and Cheshire only.
Right. Thank you. So there's lots of people saying thank you very much. Really useful. Sue Sharples, she's had to leave, but she's really interested in conclusions, the use of trauma-informed approaches. And I know Sue's done loads of amazing work in this area. I've been to her presentations, and I'm going to be talking a little bit about a case study in my presentation next week to follow on. So Claire's put a question here. You mentioned why abuse tends to occur in the person's home. The reason this occurs, we found out in the research by Michelle McCarthy, is that often abusers will target women with learning disabilities who have a home, and this is seen as desirable. And abusers often moving quickly. So that is where the abuse happens. So that's something that they probably found out. Have you got any thoughts on that, Rabiya?
Yeah, no, thanks for that, Claire. That's really that does make sense, and it's a theory that would be backed up by that data, would support that data, or the other way around, the data would support the theory. I think there seems to be, I think there's something about that, isn't there, about the relationship to the perpetrator as well. As you're saying, that's different for the group without learning disabilities. So for the group without learning disabilities, this all tended to happen in the perpetrator's home. So there's not just sexual abuses like Claire suggests there. There's like the financial abuse element as well of people with learning disabilities. So that's really, thank you for that input. That's something to think about.
And the sort of, which you picked up on, the exploitation as well, which is a huge issue. So another thank you from Lydia, who's my colleague. Great work, really interesting. So there's definitely a sense of appreciation, Rabiya, for sharing this research with us. It feels very, very new, very live, and that's very exciting. Joanne is also, would the abuse be in the home because they know them and maybe they go out less, e.g. less likely to have a job, so it would happen at work. So that's probably another thought here. Great question by Claire. Is this approach going to be adopted in other centres like yours? So I don't know, Rabiya, if you know of any SARCs throughout the country, if they're going to be using this screening tool or making these adaptations.
No, I don't know. I think we make a case that everyone should now, like, it'd be good, it's good practice too. We found, and it was circumstantial really that we did this for research, and then we found all of the huge clinical benefits of it. And, you know, while it's a cost, it's not a huge cost. I think it's a couple of quid for each time you use this questionnaire. And if you think about the, you know, if you're thinking about it from a health economics perspective, that's not a lot in terms of the general cost to the service, to the NHS, police service. And if it means that people are going to get a better service, then it's definitely good value for money. I don't know of other SARCs around the country that are using it yet. Like I said, that our colleagues in Australia have started using the LDSQ there, and we've been really sharing with our ethics applications and all of that. So if people were interested in doing this from a research perspective, I'd really be happy to talk to them about it. If people want to do it from just a clinical perspective, then all you need to do is introduce the tool clinically. You don't need ethics. You know, if you're not really interested in it from a research perspective, but purely from a clinical perspective, that's fine too. I think there's definitely a case for that now. I think from a researcher's point of view, I'd be really keen for this research to be replicated in other areas of the country, because, you know, we have just done this in one setting. There's nothing that makes me think Greater Manchester is going to be any different to Birmingham. So I think yes, we need the evidence for that, and it'd be good to have that research. But I think what I'd be really interested in is more rural settings and seeing what the prevalence is in more rural settings for people with learning disabilities attending there. But yeah, I'm not aware of any of that work, but I think it is important.
There's a great project being done in Cornwall with the Women's Centre down in Cornwall, a peer education project called Us Too. And Dinah was on the previous presentation, but I know that they've done lots of brilliant work. It does seem, doesn't it, like there's all this amazing work going on in the country. It's just joining it all up together and making that informed policy. That seems to be the next step. Would you agree?
Yeah, definitely. And I think that's why this campaign is so great that you guys have organised, because it has helped with that, hasn't it? It's helped think about these different pockets of work that are happening and how they connect.
Got another question here from someone who works in the learning disabilities team, who I've worked with a little bit. Do you collect any information about, have you done research about whether people coming to SARC have experienced a one-off sexual assault or experiencing ongoing abuse? So it's the sort of differences in that.
That's a really good question. It's a difficult one to answer. I think a lot of people that attend SARCs, I don't know if that's an accurate statement. I think probably the majority of people that we see, yeah, I'm confident that the majority of people that we see, it is a one-off assault. But I think for people with learning disabilities in particular, that's not, I can't extrapolate whether that's the same for the group with learning disabilities. I think thinking about this deep dive analysis that we're doing, it's a difficult one, because often the context is that somebody's reported the assault. You know, I'm thinking about cases where, so sometimes it's a third party that reports the sexual violence on the part of the person with learning disabilities. Not always, but sometimes it can be through that. So it might be that, you know, just to mention like a couple of anecdotal examples. There was once where we had a referral from the Boots chemist, and somebody with learning disabilities went and asked for emergency contraception because luckily they'd had the sex education to know about that, but they, you know, asked for it and just said that somebody had sex with them that they didn't want to. And then that we had the referral through that third party. Another time we had a referral from somebody who was just at a coffee shop, and there was somebody, and in that example it did sound like there was some financial abuse that was happening as well, that kind of came through in that person's kind of forensic medical examination, like in her general history taking. But then she's still referring to this individual as her boyfriend, and the staff felt like after she left, maybe that was you know, she might well contact him again. And it's really difficult to manage that when you're a sexual violence service. But there was definitely like that safeguarding referrals that happened, and this is always LDSQ score, I should have mentioned, it's always something that we mention in the safeguarding referrals. So it's difficult to say, you know, if it's a one-off assault or not. In that occasion, like the coffee shop example, that was clearly somebody who was the boyfriend, and you know, and he was physically assaulted her, and that's why the coffee shop called the police. But in the person's conversation with the police, they mentioned that that person sometimes has sex with them when they don't want to, and that's how they came to us.
Mm-hmm.
But in that case, it felt like maybe that was a repeated assault over multiple occasions. I can't answer that from the data we have. I think that's a really important thing to think about. And I will think about that more and think about how it is we can analyse that from the existing data we have.
Thank you.
I imagine the repeat assaults are among the ones that aren't reported.
Okay. Thank you for that. I'm aware you're being put very much on the spot with this, but what it reminds me of also is the importance, you know, thinking about people who work in coffee shops, people who work in boots. This is not something that, this research is not just something that kind of professionals who work in this, who work in these settings need to know about. This is a public message, isn't it, that needs to be kind of spread if we're going to, you know, support people. There's one more comment, I think. We'll have great work, Rabiya and team. Stats on perp type and abuse location were particularly thought-provoking. With consent, having the info from LDSQ passed on to ISVA would really be useful for improving follow-up support for ISVAs too. So there's that acknowledgement there.
Thank you. Well, we do, as part of our integrated service, obviously our ISVAs have the medical notes. So the ones that are in Greater Manchester, the clients that attend, they'll attend for the forensic examination at St Mary's Sark, and then the ISVA is co-located there. So they have access to all of the medical notes. So they know the person's LDSQ score. So definitely that's something that the ISVAs have reported has been helpful for them to have that information. When we refer our cases to our Cheshire or elsewhere ISVAs, if the person has got a score that suggests they've got a likelihood of learning disability, then we do share that information. But it's good to know that ISVAs think that's the right thing to do.
Great. Okay, I think we've got a couple of minutes, but I think we'll sort of slowly start to sort of finish things there. Did you have any other thoughts, Rabiya, that you wanted to share at the moment, or anything else that you'd like to say, or are you all good?
I'm all good. Thank you for everyone's kind of comments, and it's a tricky thing, isn't it, to deliver something like this. It's the first time I've done anything like for as long as like a long session like that, but it's nice to thank you for sticking around and like engaging in the discussion. Yeah.
Great. Yeah. It's great. It's great seeing sort of all the community come together, and I agree it's very, very weird doing this kind of time of screens, but I think you presented so well, and such a difficult subject matter to talk about. So some more thank yous coming in from people at SARSAS, you know, taking time to share your research, insightful presentation. Yes. So I think we're going to finish up there. I'll just say, you know, we've got more things. We're doing this 16 days of activism. So we've got many more things on our website, and I am doing a presentation next week. We're hopefully going to do some internal training around autism as well. So it is really, really exciting time. And thank you so much for everyone getting involved. If you've got any questions, just get in touch with SARSAS at the info email address. And yeah, I will see you all soon. Thank you very much for coming.